Thank you. Again, another change of pace. It's hard to follow you two giants. I have no disclosures other than I do treat veins from the bottom, from the top, and in the middle. I can't emphasize enough the importance of getting a good history and doing a good physical exam, especially considering proximal evaluation when you have signs or symptoms that are atypical in the leg vein patterns. I can't also emphasize enough that we need to involve the multidisciplinary approach, especially the gynecologist looking for signs and areas of endometriosis, which is the #1 cause of pelvic pain in women. So remember to involve a team. I also want to mention when we're talking about vulvar veins in pregnancy, these are obviously going to be managed conservatively. They can be very extensive, but they do tend to regress significantly postpartum. And to remind you to be careful, get out your ultrasound, and don't call this an inguinal hernia. Conservative measures would include, obviously, some kind of hormonal manipulation if patients are having cyclical pain, compression stockings, and vulvar compression if need be. And the role of venotonics is certainly helping with symptoms in my patients, and we do less treatment because of that. Now, I do want to call out, this is a great article that was just published in JVSVL, but I do want to call out this group of Brazilian ultrasonographers and surgeons, and now this has grown to be a worldwide pelvic vein work group, and call you to be involved if you'd like to, but they have shared some of their work with us, and our protocols have changed because of that. So investigating the vulvar veins, we want to do this in a standing position, obviously, to be able to get best results, and looking for reflux with a Valsalva maneuver, using a linear transducer in the perineal area rather than a curvilinear in the abdomen, and we direct by physical exam. So this is a good example of, I'm going to talk about the different leak points. This is perineal leak point. You can see the patient is standing. You can see these veins in the mid-perineum. That was the most common and more common on the right side. The inguinal escape point is a little more anterior. This is a good example of that. And again, it's a little more common on the left, and it's about 25% of patients that have these labiovulvar veins. Gluteal escape points are evaluated in this way. We just talked about persistent sciatic vein as well. And the least common is the obturator point. These are internal iliac vein branches that come through the obturator foramen and come out in this location. So we usually, in any patient that has signs or symptoms of proximal obstruction or pelvic pain, we will do a transabdominal ultrasound and transvaginal ultrasound, which is out of our scope. So the labial veins are basically pelvic leak points, and we need to evaluate and direct our physical exam appropriately. Any patients that have labial veins, we want to evaluate for pelvic pain, and we want to think about where their symptoms are. Dr. Davis, it's really the S is the most important, just like the C in SEEP. So these are the zones. Zone 1, 2, 3A is the perineum, and 3B is the leg. So look at where their symptoms are coming from, so we can define where their symptoms are and what the most disease-specific treatment should be. This is just an example of a patient with minimal pelvic symptoms. Despite the fact that she has this ovarian vein reflux, she has mostly symptomatic 3A and 3B, so labial and leg pain. So we do that from the bottom up. This is how we do it. I used to do this always with fluoroscopic guidance. I would calibrate how much volume it would take to fill those veins and then mix it with liquid or foam sclerotherapy from the bottom up. This is how we do some of our mapping in the ultrasound. We have the ultrasound doing the diameter and velocity ratios to look for obstruction as well. And then we usually do ultrasound guidance these days with a 25 gauge using foam sclerotherapy. The patient's supine or slightly upright so you can see the veins well, and that works really well for labial vein sclerotherapy. We use compression post-procedure Spanx, bike shorts, or V-supporter. We find that sometimes that lower pelvic pain will improve when we do the bottom-up approach, so I think it's reasonable if they don't have significant symptoms. If they do have significant pelvic symptoms or signs or symptoms of obstruction, pain in the pelvis, or renal symptoms, S1 or S2, then we will go to the top down. And we can find also that the perineal veins will improve after you do the top-down approach. So in summary, I would say treat the symptoms. If they have minimal pelvic symptoms, we treat from the bottom up. If they have significant symptoms, we treat from the top down. Relieve the obstruction, treat the reflux if they're very symptomatic. Look at the pelvic escape points and utilize a multidisciplinary team. Thank you.